Good evening, everyone. I'm Dr. Darrell Carter. I'm a professor of history, associate dean for equity and inclusion in the College of Arts and Sciences, and the director of the Black American Studies program. On behalf of the College of Arts and Sciences, the College of Public Health, and the James H. Quillen College of Medicine, welcome to this evening's event. I'd also like to point out a couple people. One I will introduce here in a second, but our university provost, Dr. McCorkle, who is here tonight with us, and we appreciate your presence. Thank you. Faculty, staff, students, and others, and retirees, and people in the community, thank you for taking time out of your schedule to be here tonight. This event and the planning for it began roughly a year ago. When I was having conversations with a person who has become one of my favorite people, and that is Ms. Ramona Salyer, who is Director of Development for the College of Arts and Sciences. And in her role as director and her other activities on campus, she had made acquaintances and friends over in the medical school. And when I was talking with her about a couple ideas, she reached out and said, you know, maybe you should talk to some people. And she introduced me to a couple people. And one of those people is here tonight, Associate Dean Rachel Walden from the Quillen College of Medicine. And so we started these discussions, and as those unfolded, we brought in Deans Bidwell and Blanc and Wyckoff over the preceding months, and we're able to put this event together. And I'd like to point out just how important these types of events are. They don't happen everywhere, they don't happen all the time. But what you're seeing here is the best of what ETSU has to offer. It's people, it's community, culture, the intellectual salons that we see across the campus that bring people from across the globe to our facilities. And so we are privileged tonight to have one of those global luminaries with us tonight, Dr. Hildreth, President and CEO of Meharry Medical College. Also like to point out, we talked about one ETSU, and we're seeing that here. The collaboration between myself and others, between staff members who were just instrumental in putting this together. The students who took time out of their schedules to be here. University's marketing and communication shop who helped with advertising. And so I just want to give a thank you to all of those individuals and entities that helped to make tonight happen. This event is a part of two different series, one with public health, one also with Black American Studies. And since I became director of that roughly 2 years ago, or just a little over 2 years ago, we have been very successful in reaching out and collaborating, and it's been really heartwarming to have people who wanted to respond in kind, who wanted to be a part of it. And that's not always the case in academic life, where we are trained to work in our fields. We get in these academic silos and we stay there. But this is illustrative of what we can do when we work together. And so I thank Dr. Nolan for his leadership, his visionary leadership, and the leadership of the University Provost, Dr. McCorkle, in making these events happen by presenting us with not only vision, but with the ability to engage in these types of events without concern of blowback or people choosing their respective disciplines over another. And so I'm really tickled to be a part of a university that values that type of collaboration and work together. And so with that, welcome to the Carnegie Hotel. And at this point, it is my distinct honor and pleasure to introduce a man that I've known for almost 11 years, Dr. Brian Nolan, who has been our president since January of 2012. I have been around this institution as a student, fan, graduate student, faculty member, now low-level administrator for 28 years. And the vision that he brings to campus, the energy that he brings to campus, the incredible mustard pants, or gold pants to the game, it's just been tremendous. And he's been very kind to me, very kind to the College of Arts and Sciences, and to every other part of campus. And so we appreciate you, sir. We appreciate your leadership. Thank you for being here tonight. And with that, I'd ask you to introduce our special guest.
Dr. Carter, thank you and good evening. On behalf of our faculty and staff and our Board of Trustees, it's my pleasure to welcome you to the Science Lecture Series. And as I welcome you this evening, I'm reminded of this moment in time at the institution. We've just completed fall break. Our faculty, staff, and students have returned to campus, preparing to move through the close of the semester. And this is a moment in time at the institution in which we have both a sense of engagement as well as a sense of reflection. And evenings such as this are powerful because they provide that opportunity for us as a campus community to engage in thoughtful dialogue, but also to reflect upon that dialogue and examine how the things that we have a chance to be a part of tonight impact the manner in which we close through the semester and look towards the semesters on the horizon. You know, as a university, we have navigated the pandemic. As a community, we've evidenced the challenges that have faced this community in this region, both with respect to the pandemic, political polarization, and fierce debates over virtually every part of our life. And Dr. Hildreth's address tonight will demonstrate the power of collaboration, cooperation, and vision to overcome those differences and to find a common ground. I want to take a moment to thank individuals who've made tonight possible. In particular, I'd like to thank Dr. Darrell Carter, the Associate Dean and Director of our Black American Studies program, Dr. Bidwell, Dean of the College of Arts and Sciences, Dr. Wyckoff, Dean of the College of Public Health, Dr. Block, Dean of the College of Medicine, as well as Dr. McCorkle for her academic leadership. That leadership has brought to our campus tonight a true visionary in American higher education and in American health sciences. He leads Meharry, a world-famous medical school, one that has trained African-American physicians since 1876. Meharry has been at the forefront of the American medical education in its effort to care for and treat underserved communities. In doing so, Meharry has filled a critical shortage created by historically white colleges of medicine who've ignored medical and healthcare needs of underserved and diverse populations. Our speaker tonight is a man of national and international stature. He is a renowned physician, researcher, and academic administrator. Dr. James Hildreth is the president and CEO of the Meharry Medical College. He's a graduate of Harvard University. Afterwards, due to his stellar academic performance, he became a Rhodes Scholar. He received his MD from Johns Hopkins and his PhD from Oxford. He was a professor at Hopkins as well as the University of California at Davis, and he served as Dean of the College of Biological Sciences at UC Davis. His reputation as an academic and medical visionary was in part cemented at UC Davis when he created the Kingdom Crossing program. This program involved collaborations between scientists who focused on organisms from various kingdoms of life, such as plants and animals. His work on HIV, however, included identifying a critical role of cholesterol in HIV infection, along with 11 patents and technology licenses by Green Tech, which resulted in an FDA-approved drug, Bractiva, which made him highly recognized and sought after as a figure in the field. He's a member of the Tennessee Healthcare Hall of Fame, the National Academy of Medicine, President Biden's Healthcare Equity Task Force, and the FDA's Vaccine and Biological Products Advisory Committee, which reviews COVID-19 vaccine candidates for approval. Equally important, he's a visionary and transformative leader who can make the most complex of medical and scientific topics understandable to the audiences of all levels. And if he could have made some of those tongue twisters more relatable for me, I would have been more eloquent in my introduction. Tonight, Dr. Hildreth will be delivering a lecture entitled Immunological Paradox Explained, HIV as a Trojan Exosome. It is my pleasure to welcome to the campus of East Tennessee State University, Dr. James Hildreth.
Good evening, everyone. First, I want to thank President Nolan, the Provost, Dean Block, and Dr. Carter for the amazing hospitality. This is my first visit to your campus, and I have to say it's gorgeous, it's beautiful. I really enjoyed my visit so far. I'm actually going to give you two talks. The first talk deals with COVID-19 and health equity. The second talk is to give you a 20-minute summary of 40 years of work that I've been doing on HIV. and try to convince you that our understanding of the virus is totally wrong, and that we need to rethink how we consider this virus. Okay, so, I might be sorry. Yeah. Technology is not one of my things. Okay. All right. So, I always start my talks by giving you a little bit of history about the institution that I lead, that I'm so proud to lead, Meharry Medical College. It's a truly American story, an inspirational story, and it's why I came back to Meharry as president. So we've been around since 1876. Our story actually starts in 1794, when Alexander Meharry the first left Scotland to move to New York to escape religious persecution. He then moved his family twice. They ended up in Ohio. They ended up in Ohio because Ohio was a free state. The Meharrys were abolitionists. They were deeply Christian folks. They wanted to be in a place where people were free. In 1826, the youngest of 5 brothers, Samuel Meharry, was driving a salt wagon to the backwoods of Kentucky. The wagon got stuck in the mud. Neither he nor his horses could move it. He saw a modest cabin in the distance. He knocked on the door, was greeted by a black family. Now, in 1826, in the Deep South, you might imagine that a black family might not be so eager to engage the young white man, but they did. They took him in, fed him. The next morning, they helped him get on his way. And young Sam Meharry, who was 15 years old at the time, made a promise that if we ever have resources, the Meharry family is going to do something for black folks. Fast forward 50 years, and sure enough, the 5 brothers who become really wealthy selling land warrants that they obtained from the U.S. government gave $30,000 to the Methodist Church to start a medical department at Central Tennessee College. Now, mind you, $30,000 in 1876 is a heck of a lot of money, okay? So Meharry Medical College was started by an act of kindness by an unknown black family, and that act of kindness was repaid by this young man who kept his promise. And we're the only medical school in the country that has God in its motto. Our motto is worship of God through service to mankind. So we're a different kind of institution. I just want you to keep that in mind as I talk about who we are and what we do. So the first talk I'm going to give you is about living through 2 pandemics. I started doing research on viruses in 1977 as a sophomore at Harvard University. So I've been studying viruses for, 45 years. I never imagined that I would live not through 1, but through 2 pandemics. So I want to tell you some lessons that I've learned in living through 2 pandemics. And I call my talk The Same Song, Different Melody, The Tale of 2 Pandemics. The other pandemic, which many of us have forgotten about, and is still ongoing, is HIV. So when I was finishing up my graduate studies at Oxford in the summer of 1981, 2 reports came out back to back demonstrating that on the left coast and the right coast, New York and California, young gay men were coming down with pneumocystis coronae and other opportunistic infections that should not occur in a young, healthy young man. We knew we had a problem dealing with the immune system, and unfortunately, it was given the name gay-related immunodeficiency disease, or GRID. Later that year in December, in the most prestigious medical journal on the planet, the New England Journal of Medicine, there were 4 back-to-back reports describing exactly the same thing. And unfortunately at the time, again, the thing is these were all identified homosexual men. Now, why is that important? I'll get to that in a moment. We move really quickly because 2 years later, a really colorful French scientist named Luc Montagnier, who won a Nobel Prize for his work, identified the virus responsible for AIDS. So AIDS, as you know, is a chronic debilitating disease. It's characterized by opportunistic infections. And I want to point out that HIV has never killed anyone. HIV opens the door for other things to infect us, and those other things are what do us in, because it destroys our immune system. And the CD4 T cells are really important. I'm going to talk about that in a minute. The other thing is, it almost as if HIV went to medical school, learned everything about the immune system, and has all these clever ways to avoid the immune system. We know that this is a zoonotic infection. We know now with almost complete certainty that a virus called SIV-CPZ, which is endemic to chimpanzees, is responsible for HIV in humans. This virus, if you look at the genome sequence of SIV-CPZ, is virtually identical to HIV's genome. We also know that the virus probably jumped independently into human beings at least 13 times. The epicenter for this was in the Republic of Congo, the Democratic Republic of Congo, in Brazzaville and Kinshasa. Then along rivers and railroads, the virus spread to the African continent. When it got to Point Nord here, as you see, we're thinking about 1960. That's when the virus started to spread around the world. But we know for sure that it's a zoonotic infection in which a virus jumps from one species into another. The Secretary of Health and Human Services, Margaret Heckler at the time, in 1984, announced to the world that the virus responsible for AIDS had been identified. She also virtually promised that we'd have a vaccine in 2 years. This is in 1984. So here we are, what is that, 38 years later, we still don't have a vaccine. But anyway, she thought we'd have one. What I want to point out is that the social construct at the time meant that if you were gay, you were thought to be a person doing sinful things. There was tremendous stigma associated with being homosexual. And the fact that we gave this disease a name, gay-related immunodeficiency disorder, meant that elected officials, even some public health officials, ignored it. So our president at the time, Ronald Reagan, did not mention HIV/AIDS publicly for 6 years. As a matter of fact, you can find video clips of his press secretary and other members of his cabinet mocking, deriding, and dismissing the people who had this infection. It was really awful. But because of this, the resources needed to attack the problem aggressively initially were not provided because of the social construct at the time. But I want to point out that our leader-in-chief, even after 28,000 people were dead, didn't bother to consider this a really important problem. I also want to point out that it was never a problem strictly of gay men or gay white men. Even from the beginning, if you're black, Hispanic, or white, HIV was a problem for you. Now mind you, it was a predominant problem for whites at the time, because in the left coast and right coast, there was a lot of virus around. And that's because those were ports of entry for the virus, right? That's what international travel was happening. But I just want to point out this was never a problem strictly of gay people. It affected all of us from the very beginning. I also want to point out that in the mid-90s, something really interesting happened, where the problem became less important for whites. It became much more important for African Americans. And in fact, throughout this whole pandemic, this has been a problem largely of African Americans, for the most part, and Hispanics, more so than whites. And even as I stand and speak with you today, 38 or 40 years into this, half of the cases, more than half of all the cases of HIV infections occur in black and Hispanic men who have sex with men. As a matter of fact, up until just recently, the lifetime risk of a young man aged 16 to about 30 or so who had sex with other men, the lifetime risk of getting HIV was 50%. There was a 1 in 2 chance that if you were a gay black man or a gay Hispanic man who had sex with other men, you had a 50% chance of getting infected by HIV. If we look at the global map, the same thing is true. 70% of the more than 30 million people living with HIV getting AIDS are found in the sub-Saharan African continent. The point is that here in the United States and globally, this pandemic is still one primarily of people of color. 77% of the people who have HIV infections around the world look like me. But the real point I want to make is millions are still getting infected, lots of people are still dying, Lots of people have already died. 75 million people have died since we started. The point is, this pandemic is not over. It's still a serious problem all around the world. What about the pandemic du jour? Okay, the other pandemic. COVID-19 is caused by a member of the human coronavirus group. There are 7 members of the family. The ones on the right-hand side, these 4 viruses cause the common cold. Every one of you sitting in the room has been infected by one of these, either as a child or as an adult. The ones on the left-hand side are the ones that have caused pandemics. SARS in 2003, MERS in 2012, and SARS-CoV-2 in 2019. The first 2 pandemics, they're all zoonotic infections, had something really interesting going on. There are more than 30 viruses in the whole family of coronaviruses. Most of them are endemic to bats. Bats are mammals. They give the virus to other mammals. Those mammals give the virus to us. These are the intermediate vectors for MERS and SARS. Unless you come into contact with an infected animal, you did not get SARS, you did not get MERS. In other words, animals are the vector responsible for transmission. So why did these 2 pandemics not become the major global challenges that SARS-CoV-2 did? Well, the answer is pretty straightforward. The virus is endemic to bats. There's an intermediate host. We do not know definitively what it is. When the virus got into humans, it quickly adopted for human-to-human transmission. So now instead of needing an intermediate animal vector, we became the vector, giving the virus to each other. And that's why this was such a global problem compared to MERS and SARS. We, in fact, are the vector giving the virus to each other. Let me also add parenthetically, this is a truly airborne virus. It took the CDC much too long to acknowledge that. What that means is you don't have to yell or shout or cough or sneeze. Having a conversation with someone in a normal voice, standing within 10 feet of you for more than a few minutes, is sufficient to transmit the virus. That's why the masks were so important. And the fact that masks got politicized, with all due respect, cost lives. For the simple fact that this is an airborne pathogen, and masks are designed to block it. The disease caused by SARS-CoV-2 is called severe acute respiratory syndrome. And it's because when the virus gets down into our lungs, 2 important things are happening. The virus itself is killing our tissues, but the immune response to the virus is so intense that the immune response is also damaging our tissues. That is why this is such a severe disease. But the real point I want to make is the virus starts out in the upper respiratory tract, in the back of our nose, back of our throat. There is so much virus accumulating in that place. That is why it's an airborne pathogen, because the viral load in your upper respiratory tract is so high. That's not true for a lot of viruses, but it's certainly true for this one. So what about the status currently? As of the beginning of this week, 619 million people around the world have been diagnosed with SARS-CoV-2 infection, and more than 6.5 million people have died. Let me point out to you that for every case diagnosed by a PCR test, we now know with complete confidence that at least 2 people have gotten infected without being detected. What that means that this number is probably more like 1.8 billion people around the world have been infected by this virus. Here in the United States, we have 95.3 million documented cases of COVID-19, and 1,150,000 people are known to have died. But again, based on what we know about the undocumented infections, this is probably more like 200 million people, and probably 1.5 million people may have died from COVID-19. So this is a truly global pandemic or global epidemic that has had really consequences around the whole globe. So, if we look at the timeline for COVID-19, in Wuhan, China, in December, they started noticing that people were getting unusual pneumonia. They had never seen it before. They reported this to the whole world in December, but then in January, on January the 7th, Chinese scientists isolated the virus, sequenced the genome, and published the genome. And that meant that anybody in the world who wanted to study the virus had the information they needed to start working on it. That's one of the things that made the vaccines possible so quickly. The first case outside of China happened on January the 13th in Thailand. The first case in the United States happened on January the 21st. And here's another mistake that was made, in my humble opinion. The WHO declared this a public health emergency of global consequence. They should have declared it a pandemic on January the 30th. Because at that time, in at least 13 countries, people have been infected and died. They waited until March the 11th to declare it a pandemic. That also cost us valuable time and resources. But in an eerie parallel to HIV, the 45th president of the United States, even after 5 million cases and 47,000 people dead, refused to acknowledge this as a serious public health crisis, costing lives, right? Calling it Kung flu, it'll just go away, calm down, belittling the science and the scientists who do the science. So, to me, it's really interesting that we have a situation when we have a pandemic and the person most responsible for protecting the health and safety of people in our country didn't do what they needed to do. In China, which is a fairly homogeneous nation when it comes to genetics and genomics, they made a really interesting observation after only a few months. They noticed that 7 out of 10 people who died of COVID-19 had something in common. They all had an underlying comorbid condition. They had high blood pressure, diabetes, heart disease, lung disease, stroke, congestive heart failure. Smoking was another major factor, especially for men. So why is this important? If you transpose COVID-19 to the United States, something was really predictable, which is that since minorities have a much higher rate of all of these things, it was predicted that COVID-19 would have a disproportionate burden of disease and death for brown and black people. There's more hypertension, more cardiovascular disease, more diabetes, more cancer. All of those chronic conditions in China that made people more susceptible to death are more frequent in minority populations. And sure enough, I just chose one bit of data to share with you. These are data from the summer of 2020, from Louisiana, Michigan, and Illinois, representing New Orleans, Detroit, Chicago. At one point during the pandemic, the death per 100,000 individuals was 10 times higher for brown and black people than it was for whites. 10 times higher. If you look at the cumulative data from the CDC, I know you can't read this, I apologize. If you were Hispanic, black, or Pacific Islander, or some other minority group, you were 2-fold to 3-fold more likely to be hospitalized and to die. Same thing for children. The vast majority of children who got severe COVID-19 and who died also were black and brown because they were more likely to have those underlying conditions. The bottom line is that what the pandemic revealed was this huge chasm in the health status of people in the United States. So what are the lessons that I wanted to share with you? Failed leadership because of politics and prejudice caused a delay and made our response ineffective. And as far as I'm concerned, hundreds of thousands of people are dead who could otherwise be alive were it not for this. Let me give you one example. I sit on the FDA panel that reviews vaccines for approval. And in this session where we're reviewing the vaccine for children 6 months to 5 years old, a sitting congressman from Georgia comes onto the public comment section of the meeting. It's an all-day meeting. And 1 hour in the middle of the meeting is devoted to anybody in the public who wants to say something, has a chance to. This sitting congressman from Georgia comes on and says to the 20 of us, there are 20 scientists who've been assembled to review the vaccines. When we take over Congress, we're going to pass legislation to hold you accountable for killing children. I'm a volunteer scientist who studied viruses for 40 years, lending my expertise to make sure the vaccines will be safe for children. But an elected official is accusing me of killing children. I just want you to think about that. That's just one example of what we lived through, the scientists who do this work. Many, many lives were supplanted, were lost because politics supplanted science. Here in Tennessee and all over the country. For example, in Texas, they refused to collect data because data would have pointed out that black and brown folks needed more resources than the other people did, so they didn't collect the data. These two pandemics have revealed a chasm, not a gap, a chasm in the health status of people who live in our country. These long-standing disparities that we've been talking about are best understood in something called as social determinants of health. Let me just briefly tell you what those are, then I'm going to wrap this up. The social determinants of health, as defined by the WHO, are the conditions in which people are born, grow, live, work, age, and let me add that they die. They are shaped by the distribution of money, resources, and power throughout local, state, and even global communities. The Kaiser Foundation has defined the social determinants of health into 5 categories: education and access to education, health care and the quality of the care you receive, where you live. Some of you know, you may know that your zip code sometimes is a more important determinant of your health status than anything else. The social and community context of your life. And finally, economic stability. I call these the 5 degrees of separation that separate people from good health. But there's a 6th degree of separation. One thing that the pandemic also revealed was the gap in technology in our country. Many schools pivoted to virtual learning in K-12. And a lot of communities serving black and brown kids, they could not do that because those families did not have the technology to do so. Many health systems pivoted to telemedicine and telehealth for their patient panels. Some systems could not do that because the patients we care for did not have that technology at home. Thankfully, we got a grant from the FTC to buy the technology for our patients. But my point is, technology, in my opinion, represents a 6th degree of separation. These are the 6 major things we need to deal with to make sure that everyone in our country can live their best lives and achieve their best health. So, I do want to point out one thing about technology. Some of you heard me talk about how important data science is going to be. Real-world data from clinical, medical records, social media, and all of this are being used to develop algorithms, to develop treatment plans. If those algorithms are based on data sets that do not include data from people who look like me, they're not going to be effective for me. So we got to make sure that the data sets that we use to derive the algorithms are comprehensive and represent the whole population. But more importantly, we got to make sure the people deriving those algorithms look like all of us. Because it turns out our biases are baked into the algorithms. That's why we started a School of Applied Computational Sciences, to train some of those individuals. So, the last thing I want to share with you is the real wedge separating folks that look like me from good health that we don't want to talk about, that in Tennessee we don't want to talk about, we don't want to make people feel uncomfortable. When I talk about this, I'm not saying that Dean Block is a racist. I know he's not. What I'm saying is that there are systems in place that disadvantage people who look like me. This is not about an individual thing. This is about structures that have been put in place that advantage one group over another. And the reality is, that's the reality. You cannot teach about it, you cannot talk about it, but that's reality. The real separation between good health, best health for people who look like me is this, it's systemic racism. And as a matter of fact, some organizations in our country have acknowledged this. Numerous scientific studies, we're in an academic environment here, confirm what I'm telling you. The CDC, the nation's premier public health organization, the world's actually, has declared racism to be a serious health threat that has consequences that are far-reaching and unacceptable. President Biden created this task force that I'm a part of, recognizing that this is true. And this is really astounding to think about. Francis Collins, while he was the director of NIH, the world's largest biomedical research organization, with a budget of north of $40 billion, apologized publicly for racism in the awarding of research grants. You may not know this, but if you normalize for everything, where you went to school, who you precepted with, how long you've been doing what you do, if everything's the same except that I'm black and the person I'm competing with is white, I have a much lower chance of getting my grant funded than the other person, even though everything about us is the same. This has been happening for decades. So Francis Collins, before he stepped away as director, publicly announced that he's apologizing for this, because this is real. And I can tell you that when I was at Johns Hopkins Medical School for 23 years, and I submitted a grant, the environment always got a 1, the best possible score, even if the rest of the grant was crappy. Why? Because Hopkins is Hopkins. Crappy science happens at Hopkins like everywhere else. But because Hopkins is Hopkins, you get a pass. When I submitted my grant from Meharry Medical College, which by the way has a great research infrastructure, the assumption is it's inferior, so it gets the lowest possible score. The laws of physics and the laws of nature operate the same in nature as they do with law. So why in the world would my science be so less valued, so much less, since I changed institutions? This is a reality, okay? Francis Collins apologized for it. And one of my good colleagues at the Harvard Chan School of Public Health has spent decades, because we would always say, how can you prove that racism affects health? Dr. Williams has done numerous studies that account for everything else except your skin color, and can document that if you are black and living in certain places, long life expectancy. There are some zip codes in the United States where the life expectancy difference can be as long as 2 decades. Can you imagine that in the same city, people on one side live 20 years longer than the other? It's true. High blood pressure, lower rates of vaccination, and strain on mental health are all things that can be objectively tied to racism as a cause. This health equity task force that I was a part of, we worked for 10 months, and we had 5 priorities. I'll read for you because I know you can't read this. Invest in community-led solutions to address health inequities. We call this culture of humility. Some communities have the answers, but they don't have all the resources. So when you come in and impose a solution for them, it may not be the solution they need. So we suggested to the president, invest in communities, let them solve their problems, but give them the capacity to do so. The second one is enforce data ecosystem that includes everyone, that promotes health equity-driven decisions. I share with you that in some states, if it meant that resources would go to minority communities if data were collected, they simply did not collect the data. They would tell you this. So we came up with things like social vulnerability index as a substitute for race. They quickly figured out what that was, and they stopped collecting the data. So increase accountability for health equity outcomes. I believe that CMS, which runs Medicare, should penalize large health system that may not strive to achieve the same health outcomes for all their patients. On our recommendations. We also want to invest in a healthcare ecosystem that reflects the population. Between 1908 and 2008, the percent of physicians in the United States who were Black didn't get above 3%. For 100 years, it never got more than 3%. Even today, it's only about 4.8%. Well, we know that when the healthcare provider group reflects the population they care for, the outcomes are better. Don't take my, you can look this stuff up, I'm not making this up. So we want the best outcomes. We've got to make sure the healthcare provider workforce looks like the community they're taking care of. And then finally, we want the president to create an office in the president's office to make sure all of this happens. This is what we recommended to the president. And I'm going to stop. This is the end of that first talk. Do you have any? Now I'm going to switch gears to science, but if you have any questions or comments or challenges before I go on, I'm happy to hear those. Or shall I finish this and then we'll take questions at the end? Do I have some more time, by the way? Okay.
I have a childhood question.
Sure.
The American Nurses Association also had apologized for the systemic racism in the way it has treated nurses.
Yes.
How can nurses or the nursing system and doctors, I'm a nursing professor, how can we get together and make some of this happen?
First of all, you got to decide you want to make it happen. And then the leadership of that organization has to have it as a priority. The leadership is not behind it, it's just not going to happen.
How as an individual, how myself as an individual, how can I be a positive, five-role person, priority to get some of this done?
One thing that we can do is, I believe that children cannot be truly excited about something they're not exposed to. So we're trying our best to adopt middle schools to make sure they can actually see students in professional schools, nursing, medicine, dentistry, to know that this is possible for them, right? And that's been very effective. But for individuals and organizations that are struggling with this, I'm advocating honest conversations. Okay. Conversations are really powerful, but you gotta leave the titles at the door. You gotta leave the titles at the door, just sit down and have conversations about aspirations, disappointments, all those things that make us who we are. Sometimes when I was giving talks before the age of internet and Google and all this, I would go to a conference or something, they would read my bio, and I would stand up, and people were shocked that a Black man stood up. Harvard, Johns Hopkins, Rhodes Scholar, Dr. Nelson, 11 patents. They couldn't believe that I, James Hildreth, and this poor Black kid from Canton, Arkansas. So I'm a father, right? So when we have our honest conversations, I start by saying, I am James, son of Lucy and Robert, brother to Dorothy, Charles, Burdell, Mary, and Ellen, father of Sophia and James, life-mate and husband to Phyllis. That's all you need to know about me, to know what I do, what I aspire to do in my life, right? I'm father, son, brother, husband. And I'm sure that Dr. Block here, Dean Block, from that aspect, we're more alike than we're different. Are y'all feeling me? So when you have these honest conversations, you come to realize that we're much more alike than we are different. And it really, as a biologist, it's interesting to me that the human genome for all 7.5 billion of us only differ by relatively few base pairs. But those few base pairs account for all this turmoil and hate, and it just doesn't make any sense. But when you have these kinds of conversations, at least in my experience, they can go a long way to bringing us all together. So wherever I go to talk to organizations, I always say, leave your titles at the door, go into a room, and just have some conversations. And you'll be surprised at what that can do. They're really powerful. So that's one suggestion. Is that all right?
Thank you.
Okay, so can we talk some science? I'll try to be a little bit more animated for this. So I'm going to try to convince you that the way we think about HIV has been all wrong. If we change the way we think about it, we might be able to make some progress. Because after 38 years of not having a vaccine, maybe we've envisioned this all wrong. So HIV is a positive strand RNA virus. It's an envelope virus, which means you got a lipid shell with genetic material inside, and there's attachment proteins on the surface to allow the virus to bind to target cells. This is the old schematic of what the virus looks like. Viruses are incomplete life forms. They do not have the machinery to replicate themselves. They must get inside of a cell, take over the cell's machinery, and then they can replicate. They do so by binding to a receptor. And HIV is interesting, it has two receptors, not one. CD4 and a chemokine receptor. It binds to CD4, the glycoprotein on the virus changes its shape, it then binds to the second receptor, a fusion reaction occurs, and the genome is injected into the cytoplasm of the cell. And then the nucleic acid is replicated through an enzyme called reverse transcriptase. They're called retroviruses because they do things in reverse. DNA is our genome, our genes. They become RNA, which become proteins. In the case of these retroviruses, it's RNA becomes DNA, becomes RNA again, and then proteins. So we call them retroviruses. Anyway, the genome gets integrated into the DNA of the cell. That has some really important implications because it means that when you get infected by HIV, you're infected for life. Because some of these cells that it infects have half-lives measured in decades. So when you get infected by HIV, as far as we know, you're infected for the rest of your life. That's a really important thing to remember. So then, the DNA becomes RNA again, you get translation, proteins are made, the virus is formed at the membrane, pinches off of the membrane, you have a new virus formed. My research has been focused on the first step and the last step in this process. The other thing I need you to understand to get back to our main point here is that in the immune system, we have all these cells that are part of our immune system. The adaptive immune system, the innate immune system. But the quarterback of the immune system are called CD4 T cells. They control the activities of all the other T cells. And that is why when HIV kills your CD4 T cells, your immune system is shot. If the virus targeted any other cell in your body besides CD4 T cells, you would not get an immune deficiency disorder. But because it's destroying the CD4 positive T cells, your immune system does not function very well. The other thing you know about HIV, which is really important, like to some extent like COVID-19, you get infected, the virus levels go up. We call this viremia. The CD4 indicated by the solid line here, dotted line, goes down, it recovers. This box, the virus is in your system. You can transmit the virus, but you're totally asymptomatic. The person can look totally normal, healthy, viable, going to work every day, doing all the things, but they're quietly transmitting the virus to their sex partners because they're totally asymptomatic. This can last for weeks, months. In one case at Johns Hopkins when I was there, it lasted for about 13 years in one individual. Then the virus starts replicating again, destroys the CD4 T cells, and when the T cells drop below a certain number, you get AIDS. My lab was the first lab to demonstrate that that first cartoon you saw was wrong. This is what the virus really looks like. In fact, HIV acquires multiple proteins from the cell it infects. Many viruses exclude cellular proteins. So when you have a virus particle in front of you, all the proteins on the virus or in the virus have been encoded by the virus. In other words, you can assign a gene to all the proteins in the virus because they're encoded by the virus. HIV is different. HIV looks like the cell that made it. So if it came out of a T cell, it looks like a T cell because it has proteins from T cells all over the surface. If it came out of a macrophage, it looks like a macrophage. My point is, HIV acquires host proteins on its surface and inside, and we were the first ones to demonstrate that. And it's the premise for my hypothesis that I've been trying to prove for a long time, which is this. The complexity of an organism is generally determined by how many genes it has. Human beings are wonderfully complex organisms because you have more than 20,000 genes. You can make a terribly complex organism with 20,000 genes. HIV only has 9 genes, but its biological complexity rivals that of viruses with 10 times as many genes. So the question is, how can a virus with such a modest genome have complex biology that it does? My hypothesis was, and still is, that instead of encoding the virus proteins that it needs, it simply steals the proteins from the cell it infects. In other words, if I'm stealing the proteins from the cells, I don't need to encode those proteins. My genome can be really small. That has lots of advantages for the virus. So we demonstrated that if you look at an HIV particle, again, we call it the phenotype. The phenotype of the virus looks exactly like the cell it came out of, right? So if it came out of an activated T cell, it looks like an activated T cell because that's where the protein came from. This is a really important point. I need you to put a pin in there. So we also demonstrated for the first time, as you heard from the president, that cholesterol of all things is critical to HIV replication. If you deplete cholesterol from the virus, or deplete cholesterol from the cells that are making the virus, or treat the cells with statins, of all things, you can actually reduce HIV replication. The finding that HIV needs cholesterol led us to discover that HIV budding occurs at lipid rafts, which are special parts of the membrane. After we made our discovery, we now know that dozens of viruses do the same thing. So late endosomes are the part of our cells where cholesterol metabolism is controlled, which led us to ask the question, are endosomes and exosomes part of HIV biology? That was our hypothesis. So can we link the biology of HIV to exosomes based on what I just told you? Okay, Dr. Hildreth, well, what are exosomes? Exosomes are small vesicles or particles that cells produce that have their own membrane. Okay? They are synthesized at the membranes of late endosomes. They are produced and taken up by many cell types. Some people believe that exosomes are a way for cells to talk to each other. They're just exchanging information between each other. It also turns out that they can deliver messages, mRNA, proteins, lipids, etc., and they're produced by all the cells in the immune system. Okay? So, if you study virus budding at all, this will look very familiar to you. In fact, if you substitute the intraluminal vesicles for a virus, a lot of viruses, this is how they form. So, I know they're not all biologists, so let me just walk through this slowly. This is a cell. It happens to be a macrophage. And it has a membrane that has 2 layers of lipids. And it can invaginate. It can actually enfold into itself. And when it pinches off, it makes the vesicle inside of the cell. So keep in mind that what's inside of this vesicle used to be outside of the cell. That's why it's called endocytosis. The cell is actually sampling its environment. So then something can happen. The same thing that happened at the membrane can happen with the late endosome. Invaginations can occur. And we get these vesicles formed inside of the endosome. They're called ILVs, intraluminal vesicles. And when dozens and dozens of these are formed, we call it a multivesicular body. Okay. This happens all the time with all different kinds of cells. And now, this large vesicle confused to the plasma membrane, and these things that were inside are now outside. That's why they're called exosome. Body's outside. Exome is outside, some is body. So this is how exosomes are formed. And from my perspective as an immunologist, a biologist, they're actually fascinating because they look like organelles that are outside of the cell. They have major proteins on the surface. They have signaling molecules inside. They have all kinds of molecules inside. They have RNA inside, mRNA inside. But I need you to remember that they also have MHC molecules. These are the molecules in your body that mark your cells as belonging to you. These are the molecules that transplant surgeons are trying to match. So when I connect it with somebody, it doesn't get rejected. So MHC molecules are those things that designate self as self. They're found on exosomes. They're critical to immune responses. So in 2003, my colleague, Stephen Jay Gould, the other Stephen Jay Gould, not the famous biologist from Harvard, I have my own Stephen Jay Gould. He and I published a hypothesis paper in PNAS, which is very unusual. The Proceedings of the National Academy of Sciences do not publish hypotheses normally. We beat them down because we were so convinced we were right, they published it, in which we proposed that HIV is nothing more than a glorified exosome. It's not in an exosome, it's not associated with an exosome. HIV itself is an exosome. Are y'all with me? I'm not saying that it's in an exosome, that it's not attached to an exosome. I'm saying that HIV is an exosome. Why is that important? There are two very important predictions that come out of this hypothesis. First of all, that if I am correct, the same machinery in cells responsible for making exosomes will be responsible for making HIV. Secondly, if HIV is an exosome, it can literally shape the immune response to itself, which is relevant to vaccines, as I'm going to try to convince you now. So, what is the evidence that Dr. Hildreth you not want to smoke it? If you take a cell and infect it with HIV, and that cell is also making exosomes, the same exact machinery, it's called escort, that makes the exosome makes HIV particles. If I mutate any one of those proteins involved in that pathway, I shut down exosome production, I also shut down HIV production. Any one of those proteins, or about 30 of them, knock out any one of those, exosomes stop forming, HIV particles stop forming. Secondly, if you do proteomics analysis on HIV particles and exosomes coming out of the same cells, they are superimposable. The profiles are identical except for the viral proteins. Okay. The other thing is, if you do lipidomics, proteomics is when we take a substance and we identify every protein that's present. Lipidomics, likewise, is you take some biological material and identify all the lipids. If you do that for HIV and exosomes again, the profiles are superimposable if they come out of the same cells. And glycomics, if you analyze all the sugars that are associated with exosomes and HIV, except for the virus proteins again, they're identical. And another curious thing is, whenever you isolate HIV in the laboratory and try to make a pure preparation, you simply cannot do it. It's always contaminated with exosomes. They're not contaminated. They're one and the same. That's why you cannot make a pure preparation of HIV if the cell is also making exosomes. Doesn't that kind of make sense? Okay, good. Let's keep going. So here's that machinery I was telling you about. All these proteins, they all have names, but the most important point is any one of these proteins involved in the escort pathway, if you knock them out, you don't get HIV particles. Okay. So when we published our paper in 2003, there were 22 papers in all the literature about exosomes. In 2018, there are almost 2,000 papers published on exosomes. My point is, they are now recognized in all of biology and medicine as being super important. Whether you're talking about cancer, brain function, heart function, stem cells, pregnancy, infectious diseases, exosomes have come to be recognized as pivotal to understanding lots of different things in medicine and biology. So, I'm almost there. You should come along with me. So, when we respond to different things, there are two major categories of immune responses. There's the innate immune response and the adaptive immune response. Innate immunity happens without any prior challenge to our system. These mechanisms are pre-existing. They respond immediately to a challenge. And that's through cytokines and these cells called macrophages and natural killer cells. HIV is dealt with through the adaptive immune system. It's called adaptive because you get challenged by something, your immune system learns to respond to it. The next time you see it, you get a bigger response. This is the adaptive immune response. And there are two parts to it. Antibodies, which you all know about now with vaccines, and killer T cells. We have cells in our body that when they're programmed correctly, will actually kill infected cells. You can think about it this way. The antibodies get rid of the virus is already formed. The killer cells kill the virus factories. They eliminate the cells making the virus. And the combination of these two things gives us great protection against virus infections. So, Immunology 101. Where's my young colleague, Patrick? Patrick can help me with this. So, when our body responds to something foreign in the adaptive immune system, something kind of peculiar is necessary. It must not just see the foreign thing, it must see self. In other words, it's recognizing a fragment of something that shouldn't be there, but only in the context of recognizing self. This is really, really important. I know it's kind of bizarre, but that's how the immune system works. It needs to see MHC molecules, which identify a cell as belonging there, but it also recognizes something that doesn't belong there. And those two things give you a recognition and a response. And there are two different types of these things. There's class 1 MHC molecules that deal with intracellular challenges, and there's class 2 molecules that deal with extracellular challenges. But the point I want you to recognize is that a fragment of a challenge, a virus, bacteria, whatever it might be, becomes associated with MHC molecules, and our T cells respond to that. They're seeing something foreign, but they're also seeing self. Okay? So why is that important? Well, antigen-presenting cells are responsible for educating our T cells about how to respond. They display the MHC molecules with the peptides associated with it. Our T cells see it and they respond. Are y'all still with me? It's really important. But the punchline is coming. I need y'all to be with me on this. These cells, called antigen-presenting cells or APCs, their function is to ingest things, process them, and present them to our T cells. Okay? So little pieces of the virus are now associated with MHC molecules, and our T cells respond. But here's something really interesting. Okay? It turns out that exosomes produced by antigen-presenting cells can also activate T cells. Let me say that again. Those little vesicles I've been describing to you, exosomes, if they're made by an antigen-presenting cell that's infected or has a peptide on it, the exosomes by themselves, without any cells present, can activate the T cells. In other words, exosomes can substitute for antigen-presenting cells. Think about it this way. If you're out in your garden and you get a splinter in your foot or something, and there's a response there, the presenting cells can make exosomes, release them into the blood, and sensitize your whole body by having exosomes substitute for the cells. It's beautiful. Don't y'all think? It's really beautiful, right? And fast. But the main point is, my colleague Jonathan Sprint showed back in 2003 that exosomes themselves can activate T cells. Why is that important? Well, because exosomes have all these different ways of activating cells. They can either do it directly, they can be taken up by other cells, but the point is exosomes can do this. Why is that important? Well, here's the true picture of HIV. What does that look like to you? Looks like an exosome, doesn't it? We got MHC molecules, we got co-stimulatory receptors, everything that you need to activate a T cell is present on this virus package. Because it's not really a virus, it's an exosome, right? We got one other thing I need to mention to you that's really important. Sorry, I'm a little excited. When viruses infect cells, the virus proteins get broken down into peptides, little bits of proteins, and they show up on the surface of the cells with MHC molecules. So in other words, when influenza infects a cell, influenza peptides show up on the surface of the cell so that our T cells can recognize it and eliminate it. When hepatitis infects a cell, hepatitis peptides end up on the surface. So, by extension, it'd be extraordinarily surprising if HIV infection did not result in HIV peptides being present on MHC molecules on HIV. Now, I need you to wrap your brain around this now. Here's a virus that's displaying its own peptides on MHC molecules. Y'all need to get this. Are you with me? You're in traction so far. Are you still with me?
Still with me.
We got HIV with HIV peptides on those MHC molecules. So what does that mean? What that means is something really interesting. So now when HIV encounters an HIV-specific T cell, it's going to activate the HIV-specific T cell. What does that mean? It turns out that activated T cells are the preferred target of HIV. They get infected first and they die first. So here's a virus that has the ability to identify, activate, and kill the very cell meant to kill it. Oh, y'all not working with me like this. Fiendish, isn't it? Here's a virus that has an exosome, has everything it needs to activate that cell and kill it. What's really also interesting is, if there's no co-stimulatory molecule, which some cells don't have, it gives HIV an advantage as well, because if you don't have that second signal, the T cell will kill itself, something called apoptosis. So either way, it's bad news for this T cell if an HIV comes along with a peptide on the surface that's from HIV. So think about this. As you vaccinate someone, the whole point of vaccination is to increase the number of memory cells you have that are specific for a virus. So those of you who've gotten the SARS-CoV-2 vaccine, COVID-19 vaccine, you now have exponentially higher numbers of memory cells for SARS-CoV-2 than you had before you got vaccinated. In other words, you have memory cells, T cells, that can now respond. If you vaccinate someone with HIV, and you increase the number of HIV-specific T cells, you've actually done the virus a favor. Right? So this would all be, fanciful except for one thing. As I say, this prediction at the bottom here is the one that I want to focus on. We predicted in 2003 that HIV vaccines might be a bad idea. Why? Because you might increase the risk of people getting infected. And as it turns out, in several major trials for HIV, some of which were stopped, the vaccine recipients were more likely to get infected and less likely to get infected. And no one has come up with an explanation for this But I submit to you, the explanation is obvious. When you vaccinate people for HIV, you create more HIV-specific memory cells. You increase the likelihood that HIV will run into a cell they can infect, activate and infect, making a person more susceptible. Not one trial, not two trials, 4 major trials, we made this observation, that people who were vaccinated with HIV were more likely to get infected, not less. And also in a study I really liked, one of my colleagues at University UC Davis, Dr. Silvestri, took a huge number of macaques, rhesus macaques. He took all the protocols that we use for humans for vaccines, and he tested those protocols in these monkeys. It was a rectal challenge. In other words, you're challenging the monkeys rectally to try to emulate or simulate, men having sex with men as a way of transmitting the virus. What he found was, in those animals that had high levels of activated T cells, they were more likely to be infected than those who did. In other words, the higher number of memory cells you could demonstrate, the more likely it was the monkeys got infected. Once again, suggesting, as far as I'm concerned, that vaccination creates a pool of cells that the virus prefers, giving the virus an advantage. And I'd like to suggest that if we can identify dominant peptides that HIV uses to activate T cells, let's make vaccines that don't include those epitopes as a way to vaccinate people successfully against the virus. But I'm also, you can check for yourself, the only mechanism that explains this completely is to model HIV as an exosome. And that's what we spent the last, 30 years, 20 years, whatever it is, trying to convince people of. And nothing has been published that contradicts this hypothesis. Anyone who has anything that would contradict it, I'm all ears. But I just believe that modeling HIV as an exosome would be a great thing for us to do. And this just says what I just told you. If we can identify the peptides that are associated with HIV particles, identify dominant epitopes, let's leave those epitopes out of our vaccines and give it another try. So, that's it. Thank you so much.
That's a wonderful event. I gotta tell you, as a political historian, I don't get exposed to this very often. And I was actually able to keep up with it. And so that was just terrific. And on behalf of the Colleges of Arts and Science and Public Health and College of Medicine, as well as ETSU as a whole, I'd like to present this to you for the status of honorary professor.
Thank you.
For your lecture tonight.
Thank you so much.
Also, very tickled by, the comments regarding equity and inclusion. And here at ETSU, we're working on this every day. The leadership of the president and provost on down. And, I'm happy to say tonight, for the first time, the deans Bidwell, Block, and Wyckoff have been a part of a pipeline discussion that we are having around underrepresented groups that we will have more information about in the next few months. But it will focus on some of those disparities by helping students as they're coming in from high school into university here going forward. And so we'll have more information on that later, but I think Dr. Hildreth points out a number of things that we would be well served to not only hear, but also act upon as we move forward with our respective work across this campus and beyond. So With that, thank you for being here tonight. I appreciate you. Please also speak with Ms. Ramona Sallier and our other development officers, because these events are not free. And we make them free because we believe in that. But it's not cheap. We have to pull resources. We have to, use staff. We have to pay for things like this. And so to continue that and the great work that's happening across this campus, please consider making a meaningful donation to East Tennessee State University. Thank you and good night.